Good evening and happy National DNP Week. I'm Devyn Nixon and I'm joined by Dr. Danielle McCamey and our speakers for this evening. Listen, you're in the right place, but we've got some quick housekeeping. We want you to know that we are recording the session. You can drop your questions in the chat. We'll hold Q&A at the end of each talk. Tonight, we'll explore rest as a clinical imperative, a catalyst for practice transformation, and the nurse's voice in policy. But before we get started with our first speaker, I want to hand it off to Dr. McCamey for a little bit about DNP Week. Dr. McCamey?
Thanks, Devyn. I really appreciate the intro and welcome everyone to the second annual National DNP Week. I wanted to give everyone an opportunity to learn about how this came about and just to share a little bit about the theme before we get started. But thank you for spending your evening with us tonight. Every good thing starts with a story. And so the story behind National DNP Week happened last year. I was chatting with some colleagues, DJ Kirk and Stephen Davis. And Stephen Davis and I had done a webinar together for Georgetown University around the impact of DNP prepared nurses. And while we were preparing for that presentation, we took note that it was the 20th anniversary of the DNP degree because AACN back in 2004, along with their member organizations, had signed off on um, implementing the DNP as the clinical doctorate for uh, advanced practice. And so I said, you know what? We should just go ahead and make a DNP week. And um, when I looked at some of the dates, the founding date of DNPs of Color was October 19th. We decided to make October 20th National DNP Student Day. So happy National DNP students. And then October 25th was the official endorsement date of the position statement for DNP in nursing. And then I said, well, let's just put it all together, the 19th through the 25th. And so here we are in our second week, and we're trying to brand it and create momentum around it to make it an official nationally recognized week because there are over 70,000 DNP prepared nurses currently in practice, which I think is incredibly significant, especially when you put us in comparison to the numbers around PhD nurses, which is probably a little bit over 10,000 nurses. So, and then when you put us all together as a nursing profession, there's about 1.5% of doctorally prepared nurses. So I think celebrating us and being doctorates in nursing practice is well deserved, and excited that you all are embarking on this branding journey of DNPs and DNP Week. Last year, we celebrated the 20th anniversary with a virtual happy hour. If you scan that QR code, you can check out the replay. We had some innovators and creatives that were instrumental in the early days of the DNP degree to the current days. So we had a really, really great time last year celebrating our 20 years. And I don't want to play it, but it wants me to play it. Sorry about that. Technology is doing what it wants to do. All right. Gotcha. So again, just recognizing National DNPs of Color Day, recognizing National DNP Student Day, and then just talking about the theme where practice meets power, DNPs driving change. This week, we felt like this theme would celebrate our unique impact as DNP prepared professionals and really recognizing that we're uniquely positioned where hands on clinical expertise meets healthcare leadership. And so we wanted to capture that in a theme. And when we think about practice, we think about the real world challenges, our experiences, the evidence based knowledge that we ground ourselves in that truly gives us the credibility and the insight to um, our why and our what. And centering the work that we do for our patients from the bedside to the boardroom, we know what it takes to make things happen. And when we think about power, having this advanced education really affords us tables and opportunities at different in different roles in different places. But most importantly, it gives us that influence that allows us to leverage our education to turn into insights and innovations that create systematic improvements across healthcare systems, policy, people, communities. And so when you add our education, our experience, it equals significant impact. And that's where our power lies. And DNP, being DNP prepared, a lot of us, our education taught us to drive change. Because we're DNP prepared, we don't just follow trends, we create them. And we're the ones having a unique ability to identify these problems, develop solutions, and make healthcare better for everyone. We are change makers, not change takers. And so, just wrapping it up with our impact and being leaders, utilizing this theme to celebrate us as DNP prepared or soon to be DNP prepared individuals and the professionals that bring the heart of bedside care to strategic thinking that's needed more now than ever before to solve big healthcare challenges, big policy challenges, big issues in the community, and uniting us to be the perfect ones to showcase our real impact and being DNP prepared. So happy DNP week. Thank you for being here. And we hope you enjoy the presentations by our speakers that will be before you soon. I will pass the mic back to Devyn.
Such a neat history. And, being forerunners is nothing new for this group. Our first speaker, Dr. Vanessa Abacan, is a clinical nurse specialist and founder of Heartfold Healing. She reframes resilience and centers rest as an ethical, clinical imperative for sustainable leadership. Dr. Abacan, thank you for leading us in this repair work. The screen is all yours.
Thank you so much. Sorry, I am using my phone to know which slide we're on. All right, so let's do next slide, please. Okay, so I want to begin with a truth we all know but rarely speak about. It's the elephant in the room. Nurses are burnt out and tired. And this isn't a personal weakness, it's a professional crisis. And that needs to be addressed. And so that's what this presentation is going to be about. For too long, we've glorified resilience while neglecting rest, as if endurance alone could sustain us through impossible conditions. But healing the healers is both an ethical and clinical imperative. When our system requires nurses to abandon their well being to keep it running, we need to acknowledge that this is not sustainable. So, in this presentation, we will reclaim rest as resistance, as safety, and as our professional duty. Next slide, please. So, the evidence for rest. The research is clear. Cho and Stege's systematic review demonstrates that nurse fatigue directly correlates with reduced vigilance and increased error rates. Lee and colleagues' meta-analysis involving over 85,000 nurses shows burnout's devastating impact on patient safety. Meanwhile, Getty's umbrella review reveals burnout affecting up to 70% of nurses globally. This isn't about lacking resilience. It's a predictable system outcome when human beings are pushed beyond sustainable limits. Psychological exhaustion is not weakness. It's our body's alarm system, warning us that something fundamental must change. Next slide. So let's talk about job stress and the safety culture gap. The relationship between job stress and patient safety culture is profound. Zabin's systematic review shows how stress directly undermines our ability to maintain safety standards. Alcidon's work reveals that leadership behavior predicts not only just staff well-being, but ethical integrity itself. Martinez Hollingsworth's national survey exposes the devastating gap when leaders don't model rest. When nurses feel unsafe voicing exhaustion, moral distress rises exponentially. The bottom line is we cannot create psychological safety for patients when we don't have it ourselves. The safety culture gap begins and ends with how we treat our caregivers, how we treat ourselves. So, if stress and culture gaps are compromising safety, where do we ground our response? And that's when we return to our code. Next slide, please. So, let me ground us in our ethical foundation. Provision 5 of the ANA Code states clearly the nurse owes the same duty to self as to others. This isn't optional language, it's an ethical imperative. Rest, reflection, and recovery, these aren't luxuries, they're professional obligations. So when we ignore our mental health, we violate our competence standards. We wouldn't allow a surgeon to operate on 3 hours of sleep for weeks on end, yet we normalize chronic exhaustion in nursing. Protecting ourselves is protecting our patients. This provision gives us permission. Nope, it requires us to prioritize restoration as part of our professional practice. And in this burnout crisis, it's time to normalize and advocate for this. So next slide, please. So the concept of resilience was meant to honor our strength. However, evidence shows it's been weaponized against us. This narrative disguises structural burnout as personal weakness, as an individual failure. When I was in patient safety, I'd look at safety events and determine system versus individual failure modes. And in this case of nurse burnout and attrition, we've somehow attributed these to individuals, aka the nurse themselves, instead of looking at the system. The message shifted from we see your pain to you should handle it better. Gupta's qualitative synthesis reveals how resilience discourse masks moral injury. Instead of fixing broken systems, we've tried to fix the nurse. And it's killing our profession. Rocker calls this performative resilience, the expectation that we smile through suffering. When resilience becomes code for tolerating the intolerable, it stops being a strength and it becomes a trap. Next slide, please. So I like looking at it with this analogy. So I'm going to share this analogy that I've always used. This is how we currently see burnout and how we're trying to solve it. Imagine driving a car with a flat tire. The vehicle can't move efficiently. The problem is mechanical, not motivational. The solution isn't finding a tougher driver who can muscle through the wobbling. It's fixing the tire. Yet, that's exactly what we've done in healthcare. We've asked nurses to compensate for chronic system defects through individual grit. We've told the driver to adapt, to be more resilient rather than fix the flat. So what happens? Over time, the rim breaks, the alignment fails, and the driver blames themselves for not steering harder. We overfunction to fill staffing gaps, skip breaks to manage impossible workloads, and then blame ourselves when we inevitably burn out. But true resilience is fixing the system, not glorifying the suffering required to survive it. True resilience means having the courage to stop the car and demand repairs. It means recognizing that endurance without restoration, it isn't strength. It's slow destruction of both vehicle and driver. Next slide, please. So, what does rest as resistance mean? It means we need to confront toxic productivity head on. The narrative that frames rest as indulgence and self-care, as weakness, has infiltrated our professional identity. But I propose a radical reframe. Rest as patient safety. Rest as survival. Rest as a collective responsibility. Every boundary we set, every break we take, every breath we consciously draw is an act of resistance against a system that profits from our exhaustion. When we rest, we're not abandoning our patients. We're protecting them by ensuring we can show up whole, present, and capable. This isn't selfish, it's sacred. And as DNP leaders, we have the unique power to institutionalize this sacred rest. Next slide. As DNP prepared nurses, we possess unique capabilities to lead this transformation. The AACN emphasizes our systems level perspective. We must redesign workflows that build in recovery time. Zaccanini and White's competencies call us to translate evidence and convert research on fatigue and burnout into operational change. We're DNP prepared leaders. We don't just cite research, we convert it into staffing models, policy reforms, and culture shifts. We position rest as a clinical safety intervention backed by data. And most importantly, we model ethical leadership that centers psychological safety. We're not just managing people. We're architecting environments where healing is possible. Next slide. So let's imagine. What if we designed healthcare spaces that actually healed the healers? Picture built-in pause protocols during high acuity shifts. Fang's work shows how structured breaks improve both efficiency and thoroughness. Imagine Somani's reflective circles becoming standard practice, creating peer networks that sustain us through trauma. Envision mindful restrooms, not break rooms with fluorescent lights and vending machines, but spaces designed for nervous system regulation. Trauma-informed leadership that honors the truth about secondary trauma. These aren't utopian dreams. They're evidence-based interventions waiting for courageous and radical thinking leaders for implementation. The question isn't whether we can afford them, it's whether we can afford not to. Next slide. So our vision needs to be transformational, not incremental. We lead wellness-based quality initiatives that track rest metrics alongside patient outcomes. We redefine success to include retention rates and moral injury indices. We build interprofessional partnerships where physicians, nurses, and administrators unite around psychological safety as a shared imperative. If Florence Nightingale were alive today, she'd be measuring moral injury the way she once measured mortality. We stop managing crisis and start preventing it. As DNP leaders, we heal systems, not just symptoms. We become architects of cultures where sustainability isn't an afterthought, but the foundation. Next slide. Let's talk about numbers that demand action. Perez-Garcia's systematic review shows compassion fatigue affecting up to 52% of nurses globally. Davidson's research reveals turnover costs exceeding $52,000 per nurse annually, and that's just the financial toll. The hidden costs are more devastating. Moral distress leading to substance use, absenteeism, eroding team stability, and more tragically, nurse suicide rates that should horrify everyone into action. When we frame rest as expensive, we ignore the catastrophic cost of its absence. Every nurse we lose takes years of expertise, relationships, and institutional knowledge. Compassion without recovery becomes cruelty to ourselves. Can we really afford not to invest in restoration? Next slide. Dean and colleagues reframe our crisis brilliantly. Brilliantly. This isn't burnout, it's moral injury. The crux of the matter is that we're traumatized by being forced to provide care that falls short of our standards. Common triggers include unsafe staffing ratios that compromise care, ethical conflicts without support, and leadership silence when we raise concerns. Moral repair requires three elements: truth telling about system failures, accountability from leadership, and genuine psychological safety to voice distress without retaliation. We need to move from band aid solutions to structural healing. Only when we name the wound correctly can we begin authentic repair, because we can't heal what we refuse to name. Next slide. So the evidence for rest as intervention is compelling. Lee's meta-analysis shows 10% increase in nurse well-being correlates with 6 to 10% decrease in safety incidents. McHugh demonstrates that structured rest reduces turnover by 22%, saving millions annually. Investment in nurse mental health improves quality, retention, and cost outcomes. Somani's peer debrief programs show sustained improvements in both retention and care quality. These numbers are not abstract. They're proof that human restoration is operational excellence. This isn't just about individual wellness, it's about system performance. When nurses rest, medication errors decrease, patient satisfaction rises, and team cohesion strengthens. These numbers are not simple coincidence. Rest creates ripples that transform entire units, departments, and ultimately healthcare systems. Next slide. Let me share a powerful example. Schwartz round, studied by Nung and colleagues, created structured space for emotional processing. Teams gather monthly to share the emotional impact of caring, not to problem solve, but to witness and validate. Outcomes are remarkable. Improved safety metrics, deeper team connections, and significantly higher retention rates. One ICU reported 30% reduction in turnover after implementing these rounds. This isn't therapy. It's professional practice that acknowledges the emotional labor inherent in our work. When we create containers for processing trauma together, we transform isolated suffering into collective strength. So, what does all of this mean for us as DNP leaders standing at the crossroads of crisis and courage? Next slide. This is our moment of moral clarity. We stand as culture architects with the power to design systems that reduce rather than perpetuate harm. Our role isn't to help nurses tolerate broken systems, but to fix those systems. We need to protect the healers while we heal healthcare itself. This requires courage to challenge productivity myths, to set boundaries against exploitation, to model rest as leadership. We redefine leadership not as administration, but as restoration. The future of nursing depends on DNP leaders who dare to say enough. Systems change when leaders change them. Next slide. DNP leaders are catalysts for change. We bridge data and humanity. We translate suffering into metrics that demand action and convert evidence into infrastructures that restore wellness. We're not trying to make nurses tougher. We're making healthcare safer for everyone. Every policy you write, every culture you shape, every moment you model rest as resistance contributes to this transformation. And you are not alone in this work. Together, we're building trauma informed systems that honor both caregivers and patients. When nurses rest, healthcare heals. When we breathe, systems can exhale. Next slide. So, as I close, I want to share where this work is taking me next. Heartfold Insights is my current project, which is a cultural diagnostic tool that translates stories and reflections into qualitative data and data back into healing. It's built on the belief that every unit has a heartbeat. And if we can listen carefully enough, the culture will tell us exactly what needs to be repaired. Using thematic analysis of nurses' lived experience, stories of burnout, bullying, moral injury, and moments of breakthrough, we can identify patterns that numbers alone miss. From there, we can design interventions that are human centered and not policy driven. My goal is to help organizations use their own narratives as clinical evidence and to let culture dictate the cure. Because when we fold every story, every wound, every act of courage into data, we don't just measure healing, we model it. And so for this project right now, I'm looking for leaders and institutions who are ready to partner in this work and make healing as trackable as harm has been. The next evolution of nursing leadership isn't about resilience, and it's about repair. And I believe that is all. That's my contact information if you want more information. Thank you so much for your time.
Wow, thank you so much, Dr. Abacan. I was jotting some notes down, and I have a question, but I always have questions. So I'm going to encourage the listeners, if you all can put a question or two in the chat, we can take a couple of those. One of the things that I absolutely loved that you said is that we don't cite evidence, we use it to transform practice. And when you're talking about looking for nurse leaders to work on the project that you're working on, I can't help but think about all the research surrounding this. We love our PhD colleagues. They do a great job researching this, but I'd love to hear more about your project. What exactly are you looking for? What end goal might you have in mind? And again, I'm going to encourage our attendees to drop a question in the chat.
I'm so glad you asked that and mentioned that because I'm very active on LinkedIn and, I share posts about burnout, about moral injury, and, healing as a whole as a nursing profession. And I've had other professionals who are also passionate about this, including PhD colleagues who have reached out and said, you want to, I think we should study this. We can, partner with this institution and run a whole study, like a qualitative study on the data that we've collected from the stories and the feedback from Heartfold Insights. And that is for sure going to be in the in the makings as I go through this process, as I go through this journey. So I'm glad you mentioned that. I do have a couple of things up my sleeve.
That's fantastic. I went ahead and dropped your LinkedIn in the chat. So those of you who, like myself, are really curious about this work and how we can support it, you can find Dr. Abacan there. I'm going to pass it to Dr. McCamey. And again, thank you so much for that wonderful presentation.
Yes, absolutely appreciate that because we're just coming off of the heels of DNPs of Color conference this past weekend in Oakland, where the theme was rest and resistance. And so that was an on time message to reinforce what we learned this past weekend. So thank you so much for that. Next up is Dr. Josh Winowiecki. Josh is an assistant professor and inaugural director of the Center for Practice Transformation, and he advances inquiry, innovation, and implementation to transform systems. Josh, please share how you've been preparing inclusive practice ready nurses. The screen is all yours.
Amazing. Thank you so much, Dr. McCamey. It is super exciting to be here. I'm so happy to share what I've been building over the last year and the way that I approach life kind of in general and how it kind of pervades into all the things that I do. But my name is Dr. Josh Winowiecki. I use he, him pronouns. I am a clinical nurse specialist and assistant professor and the inaugural director of the Center for Practice Transformation at Michigan State University. Today, I want to talk about how I and my center approach academic clinical partnerships really as a catalyst for change within healthcare. So my role to this journey has been shaped not only by my work as a clinical nurse in critical care and trauma in downtown Detroit, but my commitment to nursing education. But most importantly, I think we can all agree by my lived experiences as a queer nurse and a scholar navigating this world. I'm passionate about bridging that gap between academic expertise and the realities of clinical practice, but by making change that sticks and not by making Band-Aid fixes. So the principles that I kind of ascribe to and found all of my work in are innovation, integrity, collaboration, and this relentless focus for equity and quality. And so I bring these as foundational principles to the center and my personal commitment every day when I show up. So at the very heart of everything that we undertake at the center relies this foundational philosophy, a clear understanding of this core set of values that really serve as our North Star. And these are things that define our identity and rigorously drive our mission forward. They represent this promise that we make, not just to our patients, but to our internal team members, our partners, and every nurse and community member that we serve. But just having these defined on paper is insufficient. The real work of this is the commitment, the essential ongoing work that is found daily in tangible applications of these values, ensuring that every decision that we make, every interaction that we're in, and every breakthrough we have has purpose. So how does this actually look like? So how do we translate these principles into practice? So we do it by embedding a deeper, more radical philosophy into every facet of our operations. So for example, to live our value of diversity, equity, and inclusion, we call this equity as structure, not sentiment, meaning that equity is a non-negotiable design constraint to everything that we do. It's built into every charter from the very first meeting. Inclusion at the center also doesn't stop with who attends meetings or who's included in a team, but it's about the influence those people have. So we make sure that those who feel the change most have real proportional power to those decisions. So if I'm working with night shift nurses on a new tool, then their voices are central to that practice change. This is how you build in psychological safety to authentic partnerships. Radical humility is a really foundational concept to my personality and the way I approach life. And this means that learning happens in public. So when a pilot project flops, and we all have had several projects flop, there's no hiding behind that. We share what happened, do a postmortem, figure out what we can learn from that experience. Mentors and project leads and all of our team members are not all knowing. We are all co-learners together. We are building something together as a community at every step of the way. Whether that community is 3 people or 300 people, the value is still there, that the diversity of our thought is what leads to the strength of our outcomes. Integrity at the center is about generosity. So if we create a new tool, that person who creates it gets the credit. We build open resources so we can raise everyone's game up, not just our own. I find no point in gatekeeping information or tools or anything that I can create because that doesn't help all nurses rise up. And that's what I see as my job at the center, that every nurse and every care site across the world has all of the tools that they need to provide the best possible care. So the mission, simple but ambitious, right? So to advance healthcare excellence by empowering clinicians with the resources, the tools for evidence-based practice, quality improvement, and implementation science. And the vision, like I said, that every site where a nurse practices has someone who is skilled in evidence-based practice and quality improvement so that the nurses there can make real lasting change. So central to all of this are our academic clinical partnerships. And these are not handshakes or those meetings that just talk in a circle, but these are deep, deep alliances that are built to advance both care and learning. And so when all partners show up with an equal stake in the game, the wins are real. Nurses are better prepared in EBP, students are more engaged, there's a more robust pathway towards workforce growth. But bedside time or protected time for bedside nurses is still a problem. So there is still a lot of work to be done. So that lack of protected time, the momentum that starts to fizzle out, and sometimes the hierarchical structures that kill co-creation before it starts. I've seen tons of promising projects stall out when leaders shift, or there's not a buy-in, or frankly, when there's just a power struggle because it wasn't someone's idea. So we've talked already several times about those structural changes that are needed. And this isn't just about about willpower, but about that redesigning the system from the ground up. So our guiding operational principle is simple. Again, I try and keep things as straightforward as I can, though sometimes they have caveats. So here, I really see the center's guiding principle as practice first and scholarship follows impact. So starting with those clinical pain points, problems from the bedside, issues that nurses are encountering every day, drives the inquiry and the scholarship that we want to produce. Not a research question that seems intangible, but those that are related to actual care problems. So I see my role as a DNP prepared director of the center to be in this kind of dual habitat leadership role, where I'm taking academic frameworks and distilling them down into actionable steps for bedside nurses while brokering protected time for our clinical champions or being able to explain real clinical operations to those that may have not been in a hospital in a while and be able to speak both of those languages fluently and be able to translate back and forth is what I think makes a really successful academic clinical partner. So we are directing solving at the insufficient inputs barrier, not at the downstream outputs barrier. And so one of the foundational ways that we approach this is through a structured, transparent, agile impact workflow. So every new project begins with a brief 30-minute phone call where we co-design a logic model and conduct a pre-mortem assessment before any work begins. So we lay that foundation really early, make our group agreements that are centered in equity. And at the core of that, then, after our readiness and risk assessment, are rapid pilots. So micro pilots, focusing on small changes over 2 to 4 weeks to test that change before we commit to contributing resources. So at the end of those things, we include a very straightforward stoplight. Green means we're going to scale it up. Yellow means we iterate it down. And red means we stop and capture just the learning. So this whole process is designed to minimize risk, maximize learning, and really build momentum, but always leaving the goal of growing capacity, not dependency. And the magic to that is mentorship. So we build mentorship as infrastructure, both formal and informal, ladders of peer, non-peer, and expert mentoring, all with a clear path forward to independence. And we make scalable open source artifacts. So any template that we create or tool that's designed or layered methodology of using frameworks from implementation science and evidence-based practice in concert are made available to everyone to share. We provide templates for charters and logic models, poster presentations, impact briefings, and data collection tools so that everyone has everything they need from the beginning and we're not reinventing the wheel for every project. because the goal here is that our partners become able to lead their own change and aren't dependent upon the center to continue this work. So that brings us to the question of the night. Why is a DNP prepared nurse essential for this work? And it's because the DNP curriculum, especially combined with the background and training of becoming a clinical nurse specialist, really uniquely prepares us to be these catalysts. We're trained to think in systems, not in silos. We are equipped with the ability to apply rigorous frameworks for quality and evaluation while maintaining our position as clinical experts and innovative champions. And I think most importantly, we're educated in how to operationalize the ethical and social mandates of our profession so that when we build those systems, they're not only effective, but they're equitable and just. I think all of us have probably encountered a program or an initiative that was implemented by someone with very great intentions, but that didn't have a real touch on what implementation looks like. And I think that's one of the areas where DNP prepared nurses shine. We see the context of a situation far before many of our colleagues. We can see those pain points before they even come to fruition and really are able to navigate through things in a way that other people don't even understand because they don't think the way that we think. So all of this is an invitation, and I know I am running very fast on time as I do because I talk fast. But all this is an invitation to join us and to join this radical idea of leading with equity and integrity and honesty and generosity as the forefront, to ask hard questions and to really dig into this vision that every nurse is equipped to lead evidence-based, quality-driven change. But I can't do this alone. So I would be excited to have all of you join me in really digging into this important work in your own sites, across lines, across the country, and across the world. So I'm excited to be here and have some conversation with y'all about how we approach things and how DNPs are leading the way. And I really appreciate the time to be here and share everything with you tonight.
Wow, that was outstanding. I don't have a question, but I do have a plug that Doc's conference will be in Michigan, so I'm going to be tapping you to be
I'm
on the.
so happy you're coming to my neck of the woods.
Yes.
Again, just encouraging attendees to drop questions in the chat to keep this conversation going.
I did put a question in the comments. This is
Dr. Eisler.
yes. So
Yeah.
I can just, do you want me to say it out loud?
Sure.
Sure. Okay. So as we know, culture eats strategy for breakfast. So how do you, DNP leaders, I'm a DNP leader too, but how do we help those decision makers to not just say, yes, we support nurses, but actually follow through with providing them with what they need? So for you, Josh, obviously leading and mentoring nurses, EBPQI, and then for Dr. Abacan's, here's the evidence of support, how to care for our nurses, but how do you actually help those decision makers change their mind? Because they're part of the culture, and culture is the most difficult thing to change.
Absolutely. It's a long game answer, right? Culture shifts are baby steps and then lots of waiting and then baby steps and lots of waiting. And so I think that the magic here is storytelling, right? I think that this is where another place where DNP nurses really shine, that data by itself on a slide is not impactful, but taking those data points and turning them into a story is where I really think that you gain a lot of traction in making those cultural shifts. Saying that, we have X% turnover doesn't mean anything when you say, well, now there's 7 patients every day that are not getting the meds that they need on time. that's a far more impactful way of saying that. So I think storytelling and framing, the data points is really important, as well as, it is, as you know, Dr. Eisler, sometimes it is just taking one person along with you, and that one person that sees the change you're trying to make can then bring the next person with them. And sometimes it's just a one person at a time cultural shift.
I love that. And I want to chime in here. This is Devyn Nixon again, and just getting back from the DNPs of Color conference where I got to speak about advocacy. And this is such a sweet spot and a sweet moment for legislation and for advocacy, because most states across the nation have not started their legislative session. So I would say if there's something that we're passionate about and have evidence to support, write that policy brief, learn how to pre-file a bill in your state, and start working on reaching out to different key partners. We've been able to move some things in my state, in Washington state, and I love what you said, that it's a long game, but in the grand scheme of things, I'm working with 2 bills that we started working on about 4 years ago that are now law. So definitely encourage getting familiar with that process, and I'll drop the state legislative website's link in the chat. So if you're not sure, you can take a look at your state and that process.
Thanks, Devyn. Yeah, it's, I talk frequently about, meeting people where they are and accepting things as they are when you approach them. And I feel like, we have inherited a healthcare system that we did not create, that we are now actively trying to swim in the opposite direction and recreate something. And so it's a struggle. And I think I'm so happy I got to present with Dr. Abacan tonight, because I think that it's about that balance, right? It's about driving those change forward while taking care of yourself and making sure that you find that balance between the two, because it is a tiring work swimming upstream.
I'm looking through the chat for other questions.
I have a question. Can you hear me?
Dr. Cheryl, go ahead.
Thank you so much. And I'm off camera. Sorry about that. I was actually out walking my dog and really wanted to chime in, and so glad that I did. And thank you, Danielle, for inviting me. Very, very thought-provoking presentation. My question was in relation to your statement about equity, where you mentioned you mentioned group agreements centered in equity when you're making decisions. I find that often equity is overlooked, but sometimes not even purposely. How do you center the language when there are blind spots where, practice partners, or when you're making group decisions? How do you center language to accommodate for those blind spots and enlighten other individuals about those blind spots being there? And they might be seeing that equity is existing, or there is some fairness or whatever, and you obviously see that there is a gap. Is there a specific pathway you choose, or infrastructure or framework?
Yeah, thank you for that's a great question, and it doesn't have a real simple answer. It's really, a lot of it is situation dependent, but the tools that I find very impactful are position taking and perspective taking are really important. So if I say, okay, well, you've designed this solution. If I took this solution and put it in a critical access facility in the middle of Idaho, what would it look like there? If I then took that same solution and put it in inner city New York, what does that look like there? And now we start to have a conversation about the differences. The other is, depending on the group you're with, I have a list of those questions that you ask. Whose voice is not being heard when we approach it this way? When we approach this solution, who are we not seeing reflected in the data? Right. And so I think a lot of it is highlighting the gaps and kind of we're doing that leading a horse thing and letting people draw their conclusion, because no one likes being told that they're not being inclusive, right? Even if they're intending to be, then we can have that conversation about intent versus impact, right? Because your intent means a whole lot to you, but it don't mean a whole lot to me. So that impact does. So I think that perspective taking, positionality, and just some of those drilling questions, who are you not hearing from? Who do you not see here? What would this look like in an indigenous, health facility? Then you start to see, because you can put yourself into those other perspectives, some of those things that are missing.
Thank you so much. You have such
Yeah.
a masterful approach to equity conversations. Thank you for
So
sharing your wisdom.
thank you. Yeah, it's been 30 years in the making. So apologies, I didn't prepare more slides. I knew better. I'm a slide person to have however many slides I have is how long I'm going to talk. So I should have thrown a couple more in there, but
I've always got questions, comments. I love this discussion. And one of the things that I've learned, and I guess this is a share really, with the equity work in my community that I've been doing for years now, a lot of our medical facilities say like, these are our pillars, social justice and, equity and all of these things. But then when you lift the cover, you go, this isn't exactly what we're seeing. And just super briefly, one of the things that I noticed as a cardiology nurse practitioner was that I was seeing my patients of color in the ER, in the ICU, in the hospital, but on my clinic days, I was not seeing them. That is not who was following up. That is not who was being set up for outpatient procedures, managed on meds. And what I found, and this was like a totally other side of healthcare that I didn't even know about, was that our facility is a grant making facility. They have a whole community outreach department, a director of community outreach. And so I was able to get some evidence and propose to the organization itself, requesting for grant monies to do something about that problem. And they absolutely signed on. And here we are 5 years later, have done quite a bit with scholarship monies and conferences that the organization that says it's about these things is actually paying for. So I think sometimes we get frustrated and we haven't really asked the questions. We haven't gone down the rabbit hole of, okay, what does my facility provide to mitigate these things? And also what I learned from the other side is they were frustrated because they had all these offerings that we as clinicians just didn't know about. So they're like, how do we get people to use this funding? And as we all know, there's a bit of a disconnect at times from administration to clinicians. So I love this conversation so much. Let me hush so someone else can ask our fabulous speakers more questions about their incredible work.
All right, well, if there aren't any other questions, we will go to our next speaker, Dr. Serena Bumpus, who is the CEO of the Texas Nurses Association and practice that's grounded on advocacy that moves policy, workplace safety, staffing, education funding, and the power of nurses' voices. Dr. Bumpus, welcome. The screen is all yours.
Everyone for joining us tonight. And tonight's presentation is really about what our role is as DNP leaders in empowering nurses to become active participants in shaping health policy. So I think the presentation is timely in the conversations that we just had. And the title Nursing the Nation, it really reflects our potential to not just care for our patients, but we have to also figure out how we come together as a profession to fix the systems that serve our patients. So we can all, relate to the current healthcare landscape. There is a lot of change happening across the nation when it comes to healthcare, whether that's mergers that are taking place, or,
Serena,
changing
Serena,
uh-oh.
your sound is very robotic. I don't know if it's your headset that's kind of, it's not very clear.
Can you hear me better now?
Yes, that's much better.
Okay, all right, then I will leave the headphones off. But our current healthcare landscape is really starting to shift, and it's been shifting for a while. And as nurses, we have a really big opportunity to shape and transform the direction that we take healthcare. We also know that technology is playing a much bigger role in the work that we're doing as nurses. And what I hear often from my friends who work in healthcare technology is when they go into spaces to either pitch their ideas or work through, the emerging technology organizations, that nurses are not always at the table. And that's something that has to change. But we also have long-term issues that we've been dealing with for a very long time in healthcare. And some of them have evolved over time, some of them have exacerbated over time. And we have, again, a real opportunity as DNP leaders to help shift the narrative and change this work. But it's going to take all 5.2 million of us to move the work forward. And I don't know that we're quite there yet as a profession. And so how do we move forward? When we think about what we have to do as a nursing profession, we have to be visible first and foremost. We need to articulate our value. And that's our quick, short elevator speech that we need to create. When we think about firefighters, easy, they fight fires. Police, they fight crime. Teachers, they educate. Nurses, have we created that short little sentence of what we do? We haven't, because we do a lot. But how do we narrow that in so we can really articulate the value that we bring into healthcare every single day? And we have to, in order to do those two things, we have to be engaged. And in order to do all three, we have to feel empowered to do that. And we have to increase our influence. And we don't build influence by hoarding access, right? We build it by creating more seats at the table. And that's what we need to do for each other. And we need to make sure that nurses have a seat at every table that healthcare decisions are made. When we think about those who have come before us, nurses have always been advocates, whether it's at the bedside or in the boardroom. And we think about the early nurses who paved the way for others to enter into this profession and to continue to move work forward. They've created a path for us that we need to continue to build upon. And we know that there are nurses out there today who are leading changes in areas like staffing and mental health access, community health, health equity. And we are the trusted professionals with firsthand knowledge of what patients need. And this gives us a really powerful voice as a profession. And so, as the most trusted profession, 23 years in a row, we are the closest proximity. We have the closest proximity to our patients. We have the clinical insights that we need, but we're the least influential. And that is where we have to regain our power, is to influence the work so we can continue to change healthcare. I'm going to oversimplify the political process because this could be a whole presentation. But at the biggest point I want you to take away from this is that we cannot let the political process intimidate us. It feels intimidating, but it is truly just a process, and it is just like the nursing process. We can start just by building relationships, whether that's at the local level. We can attend town halls, we can speak to school boards, we can join local advisory councils, but then we also need to know who our key players are. Which are our legislators, our lobbyists, our professional nursing organizations, and other coalitions across our states and federally to help move our work forward. This is not something that we have to do alone. And when I talk, part of my role is talking to lawmakers. I get to do that as the CEO of the Texas Nurses Association. And I often hear from legislators that they don't hear from the nurses in their communities. And I will give you a very brief example of this, and it made a big impact for us here in Texas. We're very fortunate in Texas that our legislators do listen to nurses, and they're very supportive of nurses. We recently made some changes to our staffing legislation. Our session just ended in June, and as we were pushing that legislation forward, the chair of our calendars committee was not moving the legislation to the House floor. And when we talked to his staff about why that wasn't happening, he told us that he wasn't hearing from nurses in his district. And so therefore he didn't think it was really an issue. And so we called our members in his district and said, hey, we need your help. And this particular nurse that we phoned, she says, I'll do something better than that. I will write a letter expressing just how important the staffing legislation is. And I will get all of my best nursing friends to sign this letter with me. And so she wrote a very compelling letter about why the staffing legislation needed to be passed, and got 150 signatures from the nurses in her healthcare organization that worked in his district to sign onto that letter. And he ended up moving that legislation forward to be heard on the House, and it passed unanimously in both the House and the Senate after that. But the takeaway here is that there are a multitude of entry points for nurses to get involved, and you can be as engaged or as much or as little as you want. As I mentioned, the nursing process and the political process are very, very much the same. We do this work every single day when we're caring for patients, and we can do the same work as we're trying to shape healthcare policy. And we don't have to do it alone. When we think about politics and the value that our professional organizations and coalitions bring, all politics are local. Local is the individual, right? And so as individuals, sometimes it is really hard to move legislation forward. But your professional organizations also can't be effective unless they have members helping push that work forward. And so the successful influence comes when the organizations and the individuals work together. And I will share, there is data out there that shows that less than 10% of the nursing population here in the United States are members of a professional nursing organization. And so there's an opportunity for us right there. We aren't visible through our professional organizations. We aren't articulating our value through our professional organizations, and we're not engaging with them. And so we have a big opportunity to shift that. And as DNP leaders, we can help influence that and bring other nurses on that journey with us. And so when we think about how we actually advocate, it really does start with those professional nursing organizations. They have the tools and the resources to help move your interests forward, and they want to move the interests of the issues in your area, in your states forward, and nationally. But as we also need to build those relationships with our legislators. That is critical. And while our states and even federally right now, while they're not in session, this is a great time to build those relationships and start talking about the issues that are important to you. They want to hear from you. They want to hear your stories. They are trying to decide where their priorities are right now. And when they hear from nurses, they can help build those priorities. But then we also can use our voices in other ways. Writing op-eds is a great way to talk about nursing issues and to bring the evidence of our issues forward and to tell our stories. That's a great platform. Storytelling, as we talked about earlier, is very powerful. Talk about the experiences and the impacts to your patients, to your peers, and to your coworkers. And it's that real world impact that we haven't done a really good job of articulating, and why some of these healthcare issues are so important to us. Advocacy doesn't have to be big to be effective. And I think that's a key point for you all to take away from you as well. But if you want to be even more involved in that, we need nurses in office, period. There are only 3 nurses in the United States Congress, and there are 19 positions in the United States Congress. And so we need more nurses serving on boards in our local communities. It doesn't have to be a healthcare board. Healthcare impacts everyone and everything. And so we need to ensure we nurses are sitting on boards in our local communities. But you can also just offer to be a resource and an advisor to your local elected officials as well. They need to hear from you. They have zero knowledge of healthcare. And the more we can educate them on the issues and what's important, the better decisions they can make. I just mentioned this already, that, nationally, we only have 3 nurses in the United States Congress and 19 positions. Those 3 nurses are Corey Bush from Missouri, Lauren Underwood from Illinois, and Jen Kiggins from Virginia. I know in my state, in Texas, I only have 2 nurses, one in the House, one in the Senate. And so who are nurses who sit in elected office in your states? I think that's important for us to know as well. If you don't know who represents you and at the state and national level, then that tells me that you might not have voted. And as nurses, we need to vote. And we have some of the lowest voter participation rates of any profession. And our voice starts with our civic duties. But then we also, again, we have to build relationships with key stakeholders and key healthcare organizations, whether that is your hospital association or other nursing professional organizations. We have to bring those coalitions together. And we need to participate on committees and serve on boards, because that's where our voices are heard. That's where our value is articulated. These are the communication and engagement strategies that we should be engaging in order to move our job transformation. There are a lot of barriers and reasons why people don't get engaged. A lot of time it has to do with time constraints or just a fear of speaking out. I think that we're seeing a lot of that right now, just in general with the current political climate. And I will tell you that we can't be afraid to speak up. We have to be able to talk about the issues and speak our minds even when our voice shakes. And so the solutions to all of this is making sure that we're educated and that we're empowered to educate others. Find a mentor in this space who is comfortable in doing this. And I have mentored a lot of people, through this political process. This is really where my heart and soul lies, and I'm happy to be that mentor for others. But then we also have to make sure that if we're leaders in healthcare organizations, that we're providing the institutional backing for nurses to be engaged in this process. I can share that, one healthcare system has created their own advocacy committee within their shared governance structure. And that advocacy committee is working with the Department of Government Affairs and their healthcare organization to bring nursing issues forward, so the organization can also advocate on behalf of nurses based off of the feedback that the advocacy committee has given. But here's your call to action. You don't have to be a policy expert to make a difference. We just have to start. And so I encourage all of you to pick one action, either join an organization, attend a town hall, primaries and are coming up. And so lots of, individuals who are up for election or running for office are hosting town halls right now. Go attend one, inform yourself, educate yourself, write a letter to your elected officials. Call and make an appointment to visit their offices. But at the end of the day, advocacy is part of our professional responsibility. It's also very deeply rewarding once you get started because you are making a difference. Whether you are making a small difference or a big difference, any difference matters right now. And so we need to use our voices as a profession to nurse the nation, not just our patients, but we need to nurse ourselves. We need to nurse the healthcare systems that are not serving us well right now. And so I challenge all of you and I call you all to step up and to step in an area that might be uncomfortable for you to really engage in this process because we have a lot of work ahead of us and there's no better group of individuals to change healthcare nurses. So I appreciate your time tonight, and I think I might have talked a little too fast, and but we'll open it up for questions if there's any.
That was incredible. I'm Devyn Nixon. I'm a DNP student, and I talk about advocacy a lot. I was really blown away by the statistic that less than 10% of nurses belong to a national association. That's definitely something I'll be taking back to my students and encouraging them to find an association that aligns with, their vision. One of the things I will say that's frustrating to me in our profession is how siloed we seem to be. And we just break off in these, little groups. And when it's time to get the work done, to lobby, we have no power in comparison to like our physician colleagues or something like that. Do you think it's in our best interest to all belong to a single association that has, a political arm and then also have the things we love like DNPs of color and our state level organizations? Or how do we just get more of a collective voice? We're so trusted. There's so many of us. And it just seems like we could be making more waves than what we are.
I agree with you 100%, Devyn. And as you were talking, I was reflecting on a situation that I found myself in where I'm part of multiple professional organizations, and one organization had a lobby day in DC where they were advocating for a specific workplace violence bill. And then a few weeks later, I went to another Hill Day for another professional organization that I was part of, and they were advocating for the completely opposite workplace violence bill. And so it was very, very frustrating for the elected official because they're like, well, what do nurses want? I mean, that was literally the question that the staff were asked. I don't understand what nurses want because you're all asking for something different. And I think, those of us who lead these professional organizations, we have to role model that behavior, and we have to come together to say, look, we're doing our profession a disservice by working against each other. And we need to come to a consensus on how we're going to manage these issues going forward, because we do work in silos a lot of times. And while there are coalitions for these national organizations, and they all, try to align as much as possible, at the same time, they're not always agreeing on everything. And that is something that we have to chip away at a great deal. But the more alliance we have, and the more consensus we have on an issue across the board, the stronger we are and the more people will listen.
I do have a question. So, yes to more nurses in office, running for office. But what if we start to see, and I used to be very strong and adamant about that until the big beautiful bill was on for voting and things like that, and nurses that are occupying seats voted, for me, my perception aligned with their party agendas over patient and community and people and humanity agenda. So, do we expect nurses once they're in office to keep the nurse cap on and their lawmaker hat?
I mean, nursing is I try to not make it my personal identity, but at the same time, it is my personal and my professional identity. And so, I don't know that I could take the hat off myself. Um, you know, I know a lot of people were disappointed when they saw how certain nurses or a nurse voted on the one big beautiful bill. And I think this is where, as nurses, we have to make sure that we're very informed about who. And I think that's a question we have to ask those individuals. Are you able to keep your nursing cap on when you are in your political environment? Because first and that's why nurses are going to vote for you. And we're the largest workforce in your district. Hospitals are the largest employers in your districts for the most part. And so those votes matter to those elected officials. And I think, when those are important questions for us to ask these individuals as they are running for office or running for reelection, to really understand how they can ensure that they're going to keep their nursing hat on when they're voting on healthcare related decisions.
So I have a question. I just want to say great presentation, and I'm so excited for DNP week. I cannot say that enough. So I've been a DNP for DNP prepared for 10 years as a family nurse practitioner. I'm from South Carolina, and so one of the nurses um, in my area, she's seasoned. Well, she actually ended up retiring. So I became a nurse practitioner as she was kind of like retiring, and I was in an association, kind of like board seat style, and they were talking about opening their own practices, and a big fuss started out. I knew that provider specifically, she had several patients, like everyone was treated by her. And so one of the DNP prepared family nurse practitioners said, nurses, we do not diagnose. And so then she had a rebuttal. She was like, how can we get ahead? We do diagnose and we do treat. And so I feel like for us to all join one association, um, we all have to get on the same page about like what we do in our profession. And then it was another one that says, well, I don't see the point of the DNP because we're all just nurses. So if you have people like that spearheading, top organizations, I just feel that it does take other organizations, such as DNPs of color, to not necessarily just reinvent the wheel, but kind of nudge it along. And I just kind of want to know your thoughts on that.
Well, and so Dr. Danny just said there's no such thing as just a nurse, and that is couldn't be more true. But we are very divided as a profession, I think too, and we have to overcome some of our own drama, if you will, to be able to move forward. And if we can't do that, then we're stuck. Um, and I think that we're starting to see a generational shift in our profession. And I think sometimes that is where some of the rift is. And if we aren't, sometimes we just have to let the naysayers be the naysayers. When there's a majority of us who know what the right thing is to do and the work that needs to be done to move things forward, then the naysayers are usually in the majority, or in the minority, excuse me. And so let the minority be, and let's continue to move the work forward that we know is the right thing to do. We do have to use our voice, and we need to hold others accountable for doing that too.
I also just
I
want to.
agree.
Right. I'm sorry. Go ahead, Dr. Coleman.
I was just saying I agree. I was not saying anything, Doc. So go ahead. I apologize.
No, I was just going to say, to piggyback on what you said earlier, Dr. Serena, that nursing, we have a branding issue. Like,
We do.
firefighters got their one liner, the police got their one liner, and so, and that was one of the mindset in creating National DNP Week, because everyone knows what a PhD prepared nurses have their one liner, but DNP prepared nurses, do we have our one liner? And so, I'm I'm glad that everyone took a chance on this anonymous profile announcing National DNP Week.
Well, you are you always are the ideator, right, Dr.
I am
McCamey?
always
So
ideating.
I don't know you very well, but I know you well enough to and have seen you in out there, that you are always the one bringing the ideas forward. So I appreciate you creating this forum. Thank you.
Yes, in an effort to unify us because of the silos that you mentioned in your presentation, and the incredible need for us to unify behind something.
Yes.
And given that there are 73,000 DNP prepared nurses, I'm like, let's just get into a week together at least and amplify the work that we do to highlight the significant contributions that we make to healthcare, our communities, and our profession. And everyone's presentation was world class. I was just texting with Devyn. I was like, I don't know these people that well. And I took a gamble on accepting people to speak for this week, and everything has been top notch, excellent. So thank
But
you all for presenting. Sorry, go ahead, Serena.
no, I was just going to say thank you, and I'm glad that you took a chance on because I think the three of us were the ones who kicked this off, right?
Yes, and y'all killed it.
Well, thank you. Well, again, you killed it by just putting this week together.
Thank you. And then shout out to Josh. Josh, did you want to share the proclamation?
Yeah, so thank you to Dr. McCamey's kind of template and some background language. We were successful in getting the governor of Michigan to proclaim this week DNP week as well. Yay. Dr. McCamey, are y'all said you're coming to Michigan next year? You're coming to Detroit?
Yeah,
Or where
we're
did you
coming to the
decide?
D. We're coming to the D.
I live downtown. We will make a day of it.
Yes, awesome. Are there any other comments before we close out the kickoff of National DNP Week for the second year?
I just want to say one more thing, Dr. McCamey. I'm gonna be honest. So when I first got my degree 10 years ago, the DNP, I had several speaking engagements, two commencement speeches fresh out of graduation, and it caused a lot of I won't say tension, but everyone wanted to know how did I land it. And a colleague called me and told me, "Were you using DNP? You're asserting it too much." And so I actually dropped it out of my name and then started going by my first name. And then a nurse practitioner that I had been knowing for a while pulled me aside and she said, I don't understand why you've dropped DNP out of your name. And then I started following you on LinkedIn. And I put, I mean, because I was one of those people that I take everything to heart. So for me, I'm a very humble person. I never just want to, rock the boat. That's just not me. But I remember on LinkedIn seeing your name and it had DNP. And I was like, oh my gosh, she's doing it. So I just wanted to commend you and thank you for actually putting it out there and making it a degree that we all should be proud of. Thank you.
Thanks for sharing. Always got to represent branding. It's branding. Dr. Cheryl, you have a comment?
I was just going to say thank you to Dr. Bumpus for her presentation, and also just mention that there's the opportunity in undergraduate and graduate health policy courses to get, like the things she shared out. I still feel like there's a missed opportunity in curriculum to have some of the policy content instilled in the courses where students can actually see that they can attend meetings and learn, from those who are actually, on the field doing it. And I think that that's not in curriculum as much as it should be.
Very true.
Thanks, Dr. Cheryl. And we'll have future Doc Devyn to close us out with her last comment.
Yes. Oh my gosh, future, 6 months and counting. Let's go. I do teach an undergraduate program and agree with that comment wholeheartedly. I shared a little link in the chat. There's just a little bit of information on some funding so that we can continue moving our work forward. We have all know about the DNP project, and just the thinking that it's more than a graduation requirement, but this is our work. Whenever I talk to PhD prepared nurses, they're writing something, they're working on something. And I sometimes wonder, shouldn't the same be so for DNP prepared nurses? What are we working on? How are we continuing our scholarship, our inquiry, and most importantly, implementation science? So, and thank you so much to all the speakers. You were all excellent. I just am blown away by day one, and I'm definitely coming back tomorrow for more.
Yes, thank you all for coming out.